Now, we had already discussed the shallow anterior chamber with low IOP. Dr. Andrew had discussed this. We will look at the other end of the spectrum. You have a shallow anterior chamber postoperatively with a high IOP. Dr. Saikumar, a prolific surgeon from Giridhar Eye Institute, he will be talking to us about the common causes and management protocols.
Thank you, TG, for having me in this course. And thank my colleague Dr. Manju Anup for helping me in this presentation. In fact, Manju does more of glaucoma work in my institute than I do now. So we all know that glaucoma filtering surgery is one surgery where you don't, want the wound to completely heal. You want it to heal only partially. And we all know that we have 4 sets of complications that you can have in the postoperative period. 2 are due to flat anterior chamber, 2 are with deep anterior chamber, and of course either you have a low IOP or a high IOP. So these are the 4 sets of complications that one can encounter in the post-operative period in trabeculectomy. And I'm going to discuss about the flat anterior chamber or a shallow anterior chamber with an elevated intraocular pressure. And basically we are looking at 3 entities here. The first one is a pupillary block, the second one is a delayed suprachoroidal hemorrhage, and the third one is the malignant glaucoma or the aqueous misdirection syndrome. The pupillary block, I think, or at least in my practice, should come in as the first diagnosis whenever you have a shallow anterior chamber with a raised intraocular pressure. So it is sedal negative, you can see the iris bombae. The AC is shallow peripherally, but centrally it is reasonably well formed. The intraocular pressure is elevated. Sometimes it can be borderline elevated or maybe slightly on the normal side, but with a flat chamber. You see a PI which is not patent. So normally you look at the area, when we do a surgical PI, we usually check whether it is patent on the table itself with the flow of aqueous at the end of surgery. But if it is not patent, it is one of the causes. Of course, you can have an air bubble which can cause a temporary pupillary block. For a very shallow chamber, if you have put in some viscoelastic, that can cause. If it is a complicated surgery or a surgery combined with cataract and you have some vitreous in the anterior chamber, that can cause a block. So whatever is the cause, the treatment to relieve the pupillary block is a laser iridotomy. So you do a laser iridotomy where there is an iris bombae and you puncture the iris, you let out the fluid and the block is immediately relieved. One entity which I do come across in my hospital quite regularly, not related to trabeculectomy at all, is a similar picture following vitreoretinal surgery. Maybe a week, 10 days, 2 weeks into VR surgery, the patient comes suddenly with low reduced vision, pain, and you examine the eye and you find that there is a lot of inflammation, the iris is stuck to the intraocular lens, and you have this iris bombae. So for that also we have to do a laser iridotomy, something similar to this. Late suprachoroidal hemorrhage is not at all common. I'm not, this is what the literature says, but we haven't seen that many number of cases in clinical practice at least. And the risk factors obviously are uncontrolled hypertension, very elderly people, myopes, when the intraocular pressure is very high, and previously vitrectomized eyes. And there is abrupt onset of nausea, severe pain. You have an inflamed eye with lot of red with a loss of red reflex, very high intraocular pressure. And posterior segment evaluation, if you can see the fundus, you can see the choroidals. Otherwise, in a B scan, you can see the choroidals. Small hemorrhages usually spontaneously resolve with topical steroids. Maybe you may require some systemic steroids and the anti-glaucoma medications. The large hemorrhage usually requires drainage once the liquefaction has occurred, which is about 2 to 3 weeks. Aqueous misdirection or malignant glaucoma is actually a diagnosis of exclusion. Once you have made sure it is not a pupillary block or a suprachoroidal hemorrhage, it's more common in hyperopes. You have a shallow anterior chamber both in the center as well as in the periphery. The IOP can range from normal to very high in the presence of a patent peripheral iridotomy. So you know that there is some collection behind the posterior capsule which is pushing the entire lens iris diaphragm forward and causing this malignant glaucoma. So the aqueous misdirection is definitely, one of the causes, and the anterior rotation of the ciliary body. These are the two factors which can lead on to the malignant glaucoma, and these are the UBM and ASOCT pictures which confirm the diagnosis. So the aim of treatment in malignant glaucoma is to deepen the anterior chamber to control the IOP, and to deepen the anterior chamber you have to have a few things to occur. One is a cycloplegia, which causes tightening of the zonules. The lens turns a bit backward. The aqueous suppressants and hyperosmotics are more important in these situations. Mild ones may help resolve with these medications. Cycloplegics are extremely important because that prevents the anterior rotation of the ciliary body and helps in treating the aqueous misdirection. So initially you probably do a peripheral iridotomy and check whether the PI is patent to exclude a pupillary block. You can do in an aphakic or a pseudophakic eye, you can do a YAG capsulotomy with an anterior hyaloidectomy. Hyaloidotomy preferably to be done in the periphery and not in the center. And in eyes with very poor vision, probably you can think of a diode laser photocoagulation. This is a video given by TG. So this is his technique, where you do a Chandler's technique, which is the 3-step procedure. First you check for the pupillary block and make sure it is patent, and then you do a posterior sclerotomy to look for a mild choroidal, and if both are not there, then just go into the vitreous cavity and let out some fluid. You need not very actively aspirate the fluid because our VR colleagues are not very fond of that. They feel that there is a lot of traction on the vitreous and the peripheral base of the retina, but you can just let out some fluid, and by doing that itself you can find that suddenly the anterior chamber is better, the eye gets softer, you can reform the anterior chamber. This is something which I intraoperatively, again not directly related to trabeculectomy, this is something which I use once in a while in the intraoperative rocky hard eye syndrome during cataract surgery. When you feel that halfway through the surgery you feel that the chamber is totally shallow, eyeball is very tight, so you can just go in with an MVR, release some fluid without actively aspirating the fluid, and that relieves the pressure and helps you continue with surgery. So in filtering surgeries, post-operative management, as we all know, can be much more challenging than the actual surgical procedure itself, and appropriate post-operative management, like all the talks that are we are hearing today, helps us in getting a good outcome. Thank you very much.
Thank you, Sai. That was an excellent talk and very clear and crisp.